Andrew said, fantastic. I've long felt that so much of the unhealthy eating is tied to shame, and so many approaches to supporting change adds to it. Totally. Absolutely. And we know that um, gay, bi, and queer men have like some of the highest rates of eating disorders, and trans people for sure, for the reasons that you stated, trying to minimize those secondary sex characteristics, regardless of what direction, we see incredibly high rates. Um, and it's especially distressing for folks who don't have other means of accessing those like affirming interventions. And so we see people who like face multiple barriers who are then uh, experiencing restricted eating or like developing eating disorders as a result in order to like try to like appear um, as their gender or be read as their gender. It can get a little dangerous. That was awesome, Cass. You definitely talked about things that nobody else tells us. So true. This is a refreshing attitude and approach. Totally true. Thank you so much. I've been learning a little bit more about intuitive eating. Some of our housemates have been kind of teaching us little bits of it. So I appreciated the little overview. And just a reminder that there will be a little survey going out about this conference, talking about all the different sessions. So if you have feedback for Cass, you can certainly pop it in the chat, as some of you have done, and feel free to share it on those surveys. The feedback will be sent to the presenters and also to us, so it'll help us continue to grow and continue to get paid to do cute things like this. So please make the government happy and say nice things about it. All right, we're gonna roll into our next session that I have queued up somewhere here. So our next session is coffee time with Karen and Corey, who are joining us here to do a little live Q&A, but they've already prepared a little session for us. So let's see if I can get that queued up. Oh, what?
The reason we pre-recorded is because we can't be in the same room together to talk, so we didn't want to do it through mass. So we pre-recorded so we could actually see facial expressions as opposed to the Rolling Stones lips on my face and whatever Corey. So
I love it.
I know the lips are pretty, and the red lipstick's nice, but it's so that's why we did it. So, but we're here live for questions and answers. So please write them down and we'll talk after we're done. Okay.
Perfect. Love it.
We're muting.
Feel free to say anything.
Okay.
Oh, I was going to say, feel free to say anything that you want about the session as I try to like pull it up right now.
Oh, I see. Okay.
If you want to like do a little preamble.
Oh, well, so we're both frontline workers. My life was addiction at one point in time before I joined Arch, and I'll tell you.
So this morning for our little session, we're going to be discussing safe supply and what that looks like for our community. Just a brief disclaimer before we jump into everything. This is the discussion taking place is intended to broaden knowledge around benefits of safe supply programs, and by no means is intended to portray expert knowledge around the strategies of implementation and claims of best practice approaches when discussing safe supply.
So what Corey and I would like to do today is a casual, comfortable way to give our thoughts and feelings on safe supply, using our skills and experiences. So skills as working in the community with folks that use substance. I also have a history of substance use. By no shape or form are we medical folks, nor do we have little documents that say so. We are just going to be telling you what we see, what we think the safe supply could do for folks from a frontline perspective. Because what we're doing right now is not working. Folks are dying, and it's here and now, and we need to do something about it. So let's start our coffee time.
Just to give you a brief introduction of who I am, my name is Corey Gillies. I began the journey into harm reduction, probably about, I'm going to comfortably say 9 years ago. I held the position at a local youth shelter as one of the staff. It quickly became apparent to me that substance use was was existing within our community. So through my position at the shelter, I actually was introduced into harm reduction by working in a local needle exchange program, often referred to as the Stay Sharp program, where I held a weekly shift. It quickly became clear of the need for more harm reduction practices throughout our community as I began to observe a rapid increase of illicit street substance use among youth. Fast forward to like 8 years later, and when I became a youth outreach coordinator for Arch, this role, which I now hold, this role has allowed me to specifically work with the youth in our community, more so like the street entrenched youth, around HIV education, prevention, harm reduction education. And it honestly allowed me to become part of like this all-star roster of folks who work towards advocating change in our society and reducing stigmas for the broader community. It's a little bit about me.
A little bit about me. As we mentioned, I am Karen Lomax. My journey with Arch started quite some time ago. I used to use Arch's services. So back in about 2011, I was in full-blown addiction. I was using crack cocaine. I was also injecting pain medicine, Oxycontin at the time. There was no fentanyl around back then. Anyway, I always had a vehicle at my disposal. So I would go to Arch and pick up harm reduction supplies. As it turns out, I would pick up for friends and deliver them and so on and so forth. At the time, we had a quirky little harm reduction coordinator who would always chat with me, ask me questions about my life, easygoing gal. Anyway, she kept saying something about becoming a peer. So after about 3 or 4 visits, I finally said, you know what, this is a great organization. I like what you do. I'm going to donate an hour of my time. How do I go about doing that? She said, donate, we don't, that's not what I was asking. What I was asking is a peer support job. It's a paid job. So imagine my surprise living in a world of full-blown addiction, being a full-blown addict, and I just got a job as a peer support worker. Kind of flies in the face of everything that I'd ever learned and been told. With that being said, I bumbled around for about a year. In that year, I learned a lot that I had a lot to bring to the table. I had a lot of insight that a lot of folks that had training and schooling and so on and so forth, they need the insight from a street level. And I had that. So after about a year of going along like this, as I said, I ended up deciding to stop using. I have been sober ever since. There has been relapses, but I've always been able to maintain an honest and frank rapport with Arch. When I started my journey with Arch and I was in full-blown addiction, they asked 2 things of me. Please don't buy and sell on shift. Do not use on shift. I thought I can do that. And I did do that. So as I sit here today, I am now the overdose prevention coordinator. And I am the one who was responsible, thank you, Course, to go around and train folks in the lock zone and hopefully save lives to folks that are dancing with the deadly fentanyl that we're seeing out there. So that's my story, and that's how I became an archer. And yeah, so here I sit. So that's me.
When we're looking at Safe Supply, I think it's important that we give like a little bit of a brief description of what Safe Supply means, because I think there's a lot of misconceptions around Safe Supply programs. So this definition that I'm going to be providing for you was provided by the Canadian Association of People Who Use Drugs, or CAPUD. They state that safe supply refers to legal and regulated supply of drugs with mind and body altering properties that traditionally have been accessible only through the illicit drug market.
This is the official meaning of safe supply. What we thought we could do is give some insight to what folks struggle with on a day-to-day basis. We can sit here and describe what safe supply should look like. But we felt if we could give you, you can't get a real understanding unless you kind of live it. So you can't really go out and live it. Well, you can, but that's not what we're doing today. So we thought if we could give you some real life examples and comparisons that you could get more insight to what folks are dancing with. So we're going to use some very common scenarios. I have fibromyalgia, so I'm going to be talking from the realm of fibromyalgia and how my life went with that. And Corey is going to.
I'm going to be discussing a comparison between a person living with type 1 diabetes with medical intervention. So it's like a little bit of a precursor for this comparison. The reason why we chose to discuss the comparison between type 1 diabetes and fibromyalgia is because we felt that the broader population would be more aware of the reality of living with type 1 diabetes. In addition to my partner was diagnosed with type 1 diabetes about 3 years ago. So it's been a significant amount of changes. And I was part of his journey as he walked through his diagnosis and what that meant for our family.
So let's do some facts. There is going to be stats throughout this, not very many, but we will get the stat part of thing for you stat folks. The facts, 2016 to 2018, we have lost over 10,000 people have died due to opioid-related overdose in Canada. 10,000 people. Between January and September of 2018, 73% of the accidental opioid-related deaths involved fentanyl or fentanyl analogs. We are not talking fentanyl that comes from your pharmacy in the patch form. We are talking about bootleg fentanyl. It comes, I've gone online, you can Google it yourself. From what I could gather, it comes in a little vitamin bottle like so. Folks are taking this much and turning it into a ton of street drugs. It gets cut with all kinds of things. This is from what I can gather online. You can go and research it yourself. To a non-addictive person, 2 grains of this, so the size of salt, is enough to kill somebody. So what's happening is drug dealers are taking this little bottle, putting it in a big mixing bowl, and putting cut in it, whatever that would be. We've seen horse tranquilizer to benzodiazepines to just anything that they can bulk it up. Put that in a big vat, stir it around like you're making chocolate chip cookies, and then dispense it out, and it's sold to people. The problem is with that, like a batch of chocolate chip cookies, you can't guarantee after you've stirred it that 25 chocolate chips get in each cookie. And what's happening is we're getting more fentanyl in one package and less fentanyl, or vice versa, which creates hotspots. So the general public that is going out to buy this fentanyl from the drug dealer, even the same package, the morning shot could be less potent than the afternoon shot, and it could overdose them. It could have that 1 extra grain or that 1 extra chocolate chip in it, which is enough to overdose them. So even knowing your own dose can be a problem in this day and age.
Okay. Karen, are you comfortable to move on to our comparison?
Absolutely.
Okay. So I'm going to start the comparison talking about what me and my partner's journey looked like when we found out he was diagnosed with type 1 diabetes. First and foremost, it took us a long time to achieve the diagnosis. We weren't really aware what was happening. All we knew is that there was significant thirst and, more frequent trips to the bathroom. Finally, my partner drove himself to the hospital and was admitted immediately. There was no hesitation. There was no wait in the waiting room. They saw the color. His color was gray. They admitted him immediately. No questions asked. He was sent not just through Emerge, but all the way up to the 3rd floor of the hospital. So there was Again, no barriers in that process. Came into the hospital, was admitted, taken to the 3rd floor, no questions asked. So, and then we found out through blood tests, actually, they assumed that he had known. They were like, well, why would you drink that much Mountain Dew specifically if you're type 1 diabetic? So they assumed he knew. He didn't know. Was 34 years old, never had problems like this prior in his life. So upon the diagnosis at the hospital, he was actually kept for like 3 days to make sure he knew how to inject his insulin, when he needed to inject his insulin, the areas of the body that he needed to inject his insulin into, and what the different types of insulin that they would be providing him, what they would do with his system, and how they would work with his body. Also, just to make sure his sugar level was coming back down. So upon type 1 diabetes diagnosis, the hospital then provided referrals to like specialized practitioners that specialize in diabetes care. From that point on, once he connected with his endocrinologist, an individual plan of care is then initiated. So the individual plan of care consisted of, making sure his sugar level was staying into normal. Conversations around it's going to take a while for your sugar level to become back to normal. This is what's going to happen to your body during those times. I'm really grateful for those conversations because my husband, it actually impacts the eyes. So he wasn't able to focus with his eyes for about 2 days because of his his body regulating his sugar and his sugar level being so high. He couldn't focus. So he wasn't able to drive. He wasn't able to attend work. But those conversations were had. We knew those things, so we knew what to expect. So once the individualized plan of care comes into play, it encompasses a means of monitoring sugar levels. So access to prescriptions for injectable insulin, as well as prescriptions for all of the specialized paraphernalia that goes with type 1 diabetes. Some examples of this are like insulin pens, pumps. So some people have insulin pumps where it just automatically gives them their insulin dose when it's needed. Sensors, strips, glycol readers, syringe tips, quick and long-lasting insulin. And a benefit to this is most of his prescriptions we can refill via phone call. So it's not him having to go into the doctor every time. And with type 1 diabetes, he's taking 2 different pens. Sorry, I keep on waving my hand off the camera. 2 different pens at least 3 times a day. So again, these pens, they're about this big. They come with special syringe tips on the top. You have to have a prescription to refill the syringe tips, as well as the individualized pens. We are fortunate enough and privileged enough that he has access to being able to have a 2-week sensor that just he can put into his arm. It reads through his phone. Not everybody has access to this. Other people are doing the glucose monitor where they're testing their sugar level by a prick on the finger and using the strips. Again, those are all required of prescription. So then from that point, the plan of care also includes referrals to optometrists. So with type 1 diabetes, we know the impacts that it has on the body. It can significantly impact the eyes, the feet, the dental hygiene, the mouth. So with his plan of care, this includes yearly referrals to optometrists or eye doctors, referrals to podiatrists, pardon my that one's a fun word for me, or foot doctors, right? Because insulin is very hard on the circulation. He gets regular dental checkups, so that's at least once a year. Regular access to nutritional experts. So if he's feeling he needs to have a conversation with his dietitian, that appointment can be made whenever he needs. He just has to phone it in. And then he also has quarterly appointments, so 4 times a year, with an endocrinologist to reassess his plan of care. So that's every 3 months, he'll go in to meet with his endocrinologist and they'll do an assessment. They'll do how his sugar levels have been for the last 3 months, if they've been consistent, if there needs to be a change in insulin. So again, this is looking at a situation where there is medical intervention available. That was kind of our little journey. before we had even left the hospital, they had connected us with a dietitian. They came right into the room, not just had a conversation with him, but also pulled me as his like partner aside and like was like, these are the things he's going to need to change in his diet. This is the way he needs to be structuring his eating on a regular basis. These are all the things that were provided to us in like within a matter of days of this diagnosis. So that's again just a little bit of an overview of what a situation can look like with medical intervention in place. And then I'm going to hand it off to Care Bear here.
If I could get the unmute button to work. With that being said, as Corey spoke, you're sitting there and I was nodding. Yes, that's what it should be like. Yeah, absolutely. That's our healthcare system. That's how I would expect it to run. So now I'd like to give you my story, my synopsis with fibromyalgia and how my medical journey looks so much different from Corey's. So 15 years ago, I was diagnosed with fibromyalgia, which is a condition that causes widespread pain. Not a lot's known about it. I was referred to a specialist in Toronto, one of the leading fibromyalgia folks in Toronto. And the way they diagnose is they kind of poke in certain areas, and it's very sensitive to a fibro person. So, and that's how his little test was. And I just want to add this because he got such a kick when I lifted off the table every time he hit me in these little spots. He said, that's the best part of my job. So anyway, with that being said, I was being looked after by a specialist, a leading specialist with fibromyalgia. Unfortunately, he ended up passing away. So when I talked to the receptionist, what are we doing? Where are we going? Are we being referred to another specialist? What they were doing is referring you back to your family doc. No problem. I'd been with my family doc for 20 years. He had birthed all 3 of my children. Up until this point, he had taken care of all my ailments from sore throats. He was the one who referred me to the specialist, da-da-da-da-da-da. So I come back with my family doc. I tell him the story that, Dr. da-da-da has passed away and I'm on this medication and it needs to be changed over to you. Unbeknownst to me, at this time, I had an uncle, our family's not particularly close, had an uncle who had had a hiccup with drug seeking. So once I let the doc know that I was on these pain meds, which were Oxycontin at the time, he said to me, unfortunately, you're not going to be able to get them from me. There's a history of family addiction. And he kind of gave me a little bit of background about what had happened, that I had a family member drug seeking. So addiction runs in the family. So I was not getting my medication from him. That was my first experience with being classified as maybe having a problem and was cut off before I even got started. I then discovered there was quite a black market for such meds. So that is when my dance with the streets began. A person living with substance use disorder in the perfect world will not tell a doctor that they have a hiccup. Even being on methadone for so many years, if I go and see a new doctor now, I do not disclose I'm on methadone because the treatment changes right off the hop. Even my methadone doctor will say, do not disclose that until you have to. And I don't. If I'm going for surgery, I will then let them know I'm having methadone at that. I have methadone at that point in time. Prior to that, I don't, because the treatment changes. For years, I had no family doctor. So I was buying my medication from the streets, had no family doctor. I tried to get a family doctor. At that point in time, I was on methadone. I let them know I was on methadone. She said, oh, well, the receptionist said, well, we'll have to call you back if we can take you on as a patient. I waited three weeks, heard nothing back from them, phoned them up as a follow-up. I was then told I was beyond the doctor's scope. In other words, they're not taking me because I'm on methadone. I don't need a methadone doctor. I have one. I needed a family doc. Was unable to get a doctor. A lot of our homeless population or a lot of our folks that are using substance can't get a family doc. Even regular folks are having a hard time with the doctor, but it's more so if you've got any kind of ailment. A lot of our street folks have a lot of our stuff taken. They don't have a health care card. So, of course, that's another hiccup. I didn't have the luxury, as Corey spoke of somebody, my point of care, that type of thing. Nobody followed up with what I was doing, how I was doing it. I was taught to inject by a boyfriend. And that was just out of convenience, so he didn't have to do it any longer. And it's not something that you can go and talk to a doctor about. Hey, listen, I'm injecting my medication. Can you show me how to do this correctly? If we had safe supply, a person could say, hey, this is how I'm doing it. Can you help me and can you do it right? And show me how to do it correctly.
I also just wanted to add too, when you were saying like you had a partner teach you how to inject, a lot of people don't even have that. They have somebody that will inject them, which then takes control away from the individual as well. I think that's just something worthy of mentioning.
Absolutely. Yeah, it's, when I wasn't able to inject myself, I had to wait for him to do his shot first, and then my shot would be. By that point in time, he was taken care of and not willing to look after me. So it was definitely a power struggle there. Definitely, that was part and parcel of it. I was lucky when I was using street grade or buying from the streets, I should say. I was on pharmaceutical grade medication, meaning I could buy Oxycontin and knew the increments that it came in and knew how much I could take. There was Hydromorph available. There was Dilaudid available. With that being said, today, with the fentanyl, as I described earlier, every dose is different. Every package is different, even if it's from the same supplier, the same color. It's that, picturing that one extra chocolate chip in that cookie that is enough to. And if you use alone, nobody can give you Narcan or naloxone. So it's imperative that we have the overdose prevention sites. If we were to hand out safe supply to somebody, they would know what they were getting every day. The studies have been just overwhelming on the fact that the folks are now going to pick up medication daily. They are now in contact with somebody that has a medical background, whether it be a nurse or a doctor, or a pharmacist, as they pick up their safe supply. It makes a world of difference. There becomes when we're using substance, because our world becomes such a private and enclosed world, the only people that are there with us are our fellow substance users. That becomes our family. That becomes that's where our knowledge comes from. That's how we learn how to do things, how to use the harm reduction supplies, because Joe Blow from Idaho told me that I needed to inject this way with the bevel up or the bevel down, or that's the end of the syringe. I mean, that's how folks are taught. With safe supply, we open up the conversation. You come and pick up your safe supply in the morning. You also pick up your needed supplies that go along with that, your harm reduction supplies, a new needle, a new cooker, water, cottons, all the things that you need. And you're not using, well, you know what you're getting because it's safe supply. That's what it is. It's safe. I mean, we've just had a rash of overdoses, and the coroner out of Toronto has done, on folks that haven't made it, and they're coming up with positive results of horse tranquilizer in their system. This stuff is not fit for human consumption. And there's no studies what happens after you've ingested horse tranquilizer for how many years. And I mean,
Even
it almost sounds like we're talking as a third world country. I mean, things are not supposed to work like that here. We're supposed to be, we have doctors, we have healthcare, we have some of these, but we don't. It's so night and day. It really is.
Well, and I think even just looking at safe supply from like a stimulant sort of perspective, there's been overdoses for people, like fentanyl overdoses or opioid overdoses for people who actively engage in substance use, like stimulant substance use. So like the cocaine, the crystal meth, right? When like seeing where the scene of the drug landscape, for lack of better terminology, from where it was, Karen, when you were engaging in illicit street substance use to what it is today, and the level of risk that is like it's skyrocketed, right? Like there's definitely been cocaine overdoses, but like with fentanyl analogs in them that have resulted in overdose death. So just this is just again just to give you like an overview of what the reality of like illicit street substances are. It may be advertised as one thing, but you're not always getting just that one thing. Not to mention the different chemicals that these substances are being cut with to make it more beneficial for the dealers, right? Like there's Drano or like different household chemicals that are also in your substances that are going into the body that are not meant they're not meant for human consumption.
So with that being said, Corey, even if a person does make it through this time safely and doesn't succumb to the opioid poisonings as we're seeing so many people, even if they make it through this time, because they've been subjected to some of these lethal concoctions, we don't know what the end results is going to be like down the road for these folks, like 5-10 years from now. And if we've also got to look at it from a financial point of view and a medical point of view, where are they going to be 5-10 years down the road when the Drano has built up in the body, and because the body can't break it down, or the horse trank can't break it down? I mean, it's just continuing to steamroll, whereas this could be so avoided. I mean, as we sit here now and we go through, well, you and I are in separate rooms due to COVID is a very prominent part of our life right now.
Mm-hmm.
It's in every newscast, it's everywhere. You know, we're I've lost where I was going with that. How wonderful
Well,
is that?
I think to like reiterate, like we're already talking about an isolated population due to stigma, right? Like, so we're already working with, when I say an isolated population, I'm referring to our active substance users. They're already facing barriers of isolation due to stigma or shame, right? Because like traditionally substance use has not been like, it's been very shame based. And we're already up against layers and layers of isolation. And now with like the COVID-19 measures, even up into this morning, we've shifted back into like phase 2, which is more restrictions. That's adding more and more walls for these people, for our folks, to be able to engage in access with supports. Like, and it's just inflating the risk of like overdose, right? Or overdose related deaths because they're being quarantined because maybe they're sick or maybe they're experiencing some form of sickness. With the implementation of safe supply programs, this is a reason for folks to come out of their house and to connect with that primary caregiver. And it also really, really engages the wraparound sort of program. So maybe first accessing all of these supports for an individual through the safe supply program is going to be overwhelming. I think that's a reality of it because they're putting them in contact with this one worker then opens up to them being in contact with like 6 or 7 different workers. So with the incorporation of like wraparound programs, they have one point worker, that works with them to access their safe supply or, access their harm reduction supplies, that is now putting them in contact with 6 other workers, but they can have one point worker to build rapport, build trust, build connection, which I think that in itself is so beneficial for some of our street entrenched folks because that hasn't been existent to them for like years of their life.
Yeah, absolutely. I mean, a lot of our folk, as we're seeing right now, are the mental health. I mean, even folks that are not using substance, mental health is wearing on people. It really is. It's getting the best of a lot of us because we don't know where this is going. With that being said, imagine if you didn't have a place to live, you didn't have food access. Any money that you do get is going to go to drugs to keep you from, going into withdrawal. In all fairness, when I was on opioids, it took the pain away of the fibromyalgia. It also took the pain away that was in my head and my heart. Some things I'm not very proud of that I did when I was addicted, but I then started to self-medicate to keep that away. You can't help but worry about that now that folks are going to be doing the exact same thing. I mean, there's nothing worse than, at least you and I today are going home, and folks that we're speaking to have the luxury of sitting here and watching this. A lot of our folks don't have this. They don't have the supports. They have each other, and that's it. And trying to survive a pandemic and also trying to survive addiction, your day is consumed with trying to find money to make the sickness go away. And then once you've got the money to buy the drugs, you then got to use, and that's playing Russian roulette. Unfortunately, the overdose prevention site is only open from 9 to 5. People do not just use from 9 to 5.
Yep.
If they can't get somebody to be with them to use, they're using alone, which is Russian roulette every time. I mean, and we can see the struggles and the trials and tribulations that we're going through to try and find an answer to the COVID pandemic, trying to come out, the research that's being thrown into coming out with a vaccine has been astronomical. And so it should be. I'm not saying it shouldn't. But I mean, there could be a simple answer to a lot of these hiccups that folks are dealing with. Once we see somebody that's stable, even on the methadone program, when folks get stable, and I'm going to talk a bit more about the methadone program and how it can be good and how it can bring up barriers, but we'll get into that in a bit. But I mean, it's a tough gig. I mean, with Safe Supply, you get somebody stable with their medication. You have taken away and eliminated what they have to do all day to try and make money to get those drugs. If you take that away, the person then goes, my gosh, I need to go and see the doctor because I've got an infection now. They start to worry about other things. They start to be able to put ducks in a row, per se, and say, okay, I'm done being on the streets now and I need to start looking for housing. They have taken a big part of, that's one of the hardest things that they do every day is trying to find substance. We have the technology. We could dispense daily, that's putting 2 or 3 pills into a person's hand or whatever for once a day. Pick them up with your harm reduction supplies and go and use wherever, at the safe injection site, so you're overseen and you're not taking deadly fentanyl. I mean, it just makes sense to me. It just does.
At that point, we are now going to have a 15-minute break. I would welcome folks to check out our Overdose Awareness Day video for 2020. It will be airing throughout our 15-minute break, but if you need to take time away from a screen, away from a computer, please feel free to do so. We will be back in 15 minutes.
Karen and Corey, is there actually a 15-minute break in the video?
Yeah, there is actually a 15-minute break.
Okay, I will leave it.
Well, we keep it running because we didn't know how to work this thing. Like, you're talking with 2 people here that have no clue about this technology.
Perfect. I love it.
Although, did you see the fun face that Karen made? She made a real fun face before we stopped for a break.
If we're not good at this, we're going to try stand-up, okay? Because, yeah.
I do just want to warn people, this video is beautiful and might make you cry. I know
Oh.
I definitely teared up the first time I watched it.
Oh, thank you, Jazz.
Uh, and as some of you learned yesterday, I had great broadcasting software that would avoid this moment of trying to finagle everything, but then it could not run at the same time as Zoom. So this is where we are today. Right. Why is that video not showing up? Right. We'll go. Let me see it. Cropped. Oh, Monty's in there.
This year has been my hardest year as being an overdose prevention coordinator. When I look in the mirror, what I do see, I see myself as first, foremost, a mother of three, a mother who loves me and has continued to support me along the way to hell and back. But I wasn't always those things. I was first and foremost an addict. I hear folks say it's their choice. They choose to be addicted. Or maybe it started as a choice of yes and no. Maybe life was so hopeless, or they don't feel they have a choice when you're in opioid hell. Does it matter how it started? No, not anymore. We need to stop pointing fingers. There needs to be choices for people, because what we're doing right now is not working. People are dying. Enough is enough. Recovery means whatever you want it to mean. It's not just abstinence. So please remember, the dead do not get a shot at recovery.
Was everybody able to hear that? I don't know if the audio. Okay. time with Karen and Corey, who will then be joining us for a little Q&A session afterwards, which I definitely want to leave time for because this is a pretty critical topic, a pretty critical time. So let us continue. If I can-
Not back on the video yet, though.
No.
Is there any questions thus far or anything like that? Apologies too if the comparison between someone being diagnosed with diabetes and someone being diagnosed with fibromyalgia wasn't very clear. The point of it was to kind of take you on a journey through the medical system. And
In England, and they were in such a mess in Scotland with heroin addiction that they started a registered user program. And this is going back maybe 20, 30 years now. With that being said, they had, I remember these statistics from then, that they had taken, there was 3% of heroin on the streets of Scotland when they did this users, and folks didn't want it, in their words, and I quote, it was shite. So they were using the safe supply as opposed to the street heroin because it wasn't any good. So that showed, and that's 20, 30 years ago. So I'm going to give you some of the stats for you stat folks of what's been taking place in London, Ontario. A Dr. Andrea, and forgive me if I'm saying this wrong, Sererda, so Sereda, has started a study, and she took on about 100 patients. Now, I'd like to tell you the folks that they're using for the safe supply studies, these are folks that have tried the methadone program. They have been on Suboxone. They have done cold turkey. They've been to treatment. They have jumped through the hoops to try and get away from this addiction. And for whatever reason, whatever has happened in their world, it has not happened. So Dr. Andrea, let's call her Dr. S, has decided to start a pilot project and to see what she could come up with and try, and she has the tools to help these folks. She can prescribe the opiates that are needed to get folks off street fentanyl. So out of 100 clients, when she first started the program, they did a general blood workup. These are the stats that she came up with. 29% of the participants had blood infections like endocarditis. With that being said, when I was in addictive, when I was using, I ended up with osteomyelitis, which was a bloodborne infection, which in fact attacked my back. It ended up eating the end plates of one of my discs. To this day, I have excruciating pain for that, and that is because of a bloodborne infection. Which probably could have been avoided, and could be endocarditis could be avoided also with proper injecting proper things. Yeah. Instead of whatever they're injecting, because we don't know what's in it. 79% of folks in this study had Hep C. 27% of the folks were HIV. 47% had a non-suppressed vermia, which, as I learned, is a medical term for some sort of virus living in the bloodstream. Now, this whatever non-specific virus could attack any organ. It has access to any organ that's in your body and could attack it at any given time. So the complications from that are just crazy. As of 2019, there has been no fatal overdoses. Now, with that being said, they did lose 3 patients. 2 of those patients were from the complications prior to the study. And one of those patients was from a non-related death. I think it was a cancer of sorts. So the results thus far, this is what they've come up with thus far. 25% of the folks have changed from injection to taking the medication orally. That's huge. they're getting their constant supply. Instead of injecting it, they've decided, you know what, this is better for me. They're able to make these decisions. There has been no cases of endocarditis since this started, which is amazing. 26% were in treatment for their Hep C. So it's proven they're able to move forward and get on with healthcare. They're in contact with somebody that's a healthcare provider and can get them into the avenues of taking care of themselves. HIV has been reduced by 10%. Homelessness, sex work, crime, all those numbers had gone down. Positive, positive, positive. I was online this weekend, and I was talking about the safe supply, and a lot of folks were concerned about people taking medication for the rest of their lives, and it causing heart issues down the road. We're not talking about down the road. We're talking about here and now. We cannot continue on like this. People are dying now, and that was one of the points that I made. It's like, we're worried about the heart condition that's going to happen down the road, but we're not concerned about the person as of today, as of tonight, as of right now. They're ingesting horse tranquilizer. We need not to be okay with that. It's not good, and it could be prevented. So that's some of the stats for you folks. And feel free to Google it, look it up, and have a look at these things for yourself. So, yeah. Okay, that's me with my stats.
Thank you for that, Karen. At this point in time, we're gonna talk about safe supply from the perspective of an ex-substance user, as well as safe supply from the perspective of a service provider. So I'm gonna jump right in. We're kind of gonna go point for point here. Karen and I are gonna have like an open dialogue back and forth. And just we're gonna bounce ideas off of each other. By all means, if you have any questions, feel free to type them in the chat, but we also have allotted time towards the end of our presentation for any live questions as well. So I'm gonna start us off here. I'm gonna be providing the perspective of a service provider. As you know, I spent a lot of time working in the youth shelter system. So the reason why I feel like a safe supply program would be very beneficial is it the very first bullet point, and to echo some of Karen's sentiment here, is it's a way for people to maintain contact or more frequent contact with service providers, including healthcare providers, housing workers, family support workers and specialized services, income support programs, treatment if they're considering treatment, and mental health supports. These are just a few brief descriptions of some of the services available.
Well, as it sits right now, so a person who does not have safe supply or is not allowed to have safe supply, they are in contact with nobody for any of that stuff. And if they're living from a homeless perspective, because we're living in the day of COVID right now, a lot of our services have been cut right down. Folks can't even get to a shower. So they are maybe coming in to use the overdose prevention site, which is wonderful, but that's only open from 9 until 5. So that contact that they do have with any service provider is very limited. It's just for the moment. You can't access any other supports. So if we were to have safe supply, folks would be in contact with I'm sure they would have to have a team. I'm sure that as service providers, we would have it set up that there would be a team that could help them. Somebody specifically dealing with housing, somebody specifically getting them going in a direction for medical care. As an ex-user, even to this day, I, for lack of better words, I'm red flagged at the hospital. If I go to the hospital today, the first thing that they write on top of my chart is methadone recipient, Oxycontin addict. Even 10 years sober, that still is red flagged. So imagine having to go to the hospital and needing help.
Even for stitches. Even for stitches.
Oh,
Something
yeah.
simple.
Absolutely. The first thing that comes out of the doctor's mouth or the nurse's mouth is, you're not getting any medication. In all fairness, I have never, no lie, touch wood, gone to our local hospital or wherever looking for pain meds. Because I'll tell you, it's a lot quicker to go down to your local drug dealer and get them, as opposed to going to the hospital and trying to explain why you would need medication. And if you're red flagged, you're not getting them. You're not getting them at all. So, you know, education is a big part. But I mean, if they had safe supply, they would be in contact with a service provider who understands addiction, who understands, that a lot of the supports are not there, and understands where they're living, and so could meet the person at where they're at.
Beautiful.
Thank you.
So the next point I'm just gonna bring up and discuss is it frees up a lot of time. So when I worked in the shelter, the amount of people that were willing to forego access to a secure bed because they needed to find substances, so they weren't going through withdrawal, like, because in certain shelters the process is like first come first serve. They only have capacity for a certain amount of individuals. And a lot of the time, what I would see being a shelter staff or working in the shelter facilities is a lot of people would willingly give up their access to a safe bed in order to be able to prevent withdrawal. So I think that's something huge and something significant, is that even these folks who are living vicariously housed or don't have access to a stable home are willing to forego that access to stability or a safe bed or a safe place to sleep to prevent going through withdrawal, because of the ache and the pain that it puts on the body. With the incorporation of a safe supply program, these people would be accessing these services and working towards, their own form of stability and what stability looks like in their life. Also, it significantly reduces health risks of contaminated substance ingestion, right?
Well, as
So
we
again,
spoke,
so again, like I work in outreach, and I work off of our community health van actually a lot, and the amount of like wound treatment and medical care that's provided off the side of a van or out the side of a van, because people are enduring different medical health, like ailments on their body because of the substance that they're ingesting, like, and the impacts on the body that it has. So just to reiterate, with like safe supply, we really reduce those health risks on the system because people know what they're ingesting. They know that it's coming from the government. They know that it's going to be regulated.
absolutely. And that just goes to show you right then and there as we speak, the van has been running for how long now, Corey?
3 years.
3 years, right? So it has built up, even though the people on the van change and the nurses on the van change, the van has made a solid foundation. And when somebody who is living life within the substance realm knows that van is coming on a Thursday night, they know that there's a nurse on that van that's going to give a rip about them, that is going to be able to look at their problems. They're going to be able to bring those problems forward and say, listen, I have a big abscess. How do I deal with this? Can you help me? Because that person that's on that van knows very well that person is not going to the hospital. They won't go. A lot of our folks won't go.
Nobody goes
That
to the
is-
hospital for an abscess.
No.
Nobody.
And you're probably sitting back going, oh my God, well, that can turn septic. Absolutely it can. A lot of our folks do turn septic, but they won't go to the hospital due to the red flag, due to the stigma that comes around being a substance user. We don't fit into the normal realm, or so we feel. But the van has built its way up to being a safe space for folks to get looked at, to get the health care needed. If we were to bring Safe Supply into, that's what we're bringing. We're bringing security. We're bringing health care to folks that need it most. I mean, you know, as we talked about earlier, what are the costs going to be down the road if we continue to ignore this? Not only the fact that we're losing lives, people are losing children, people are losing their mothers, their fathers, what have you. You know, what is this going to cost down the road? I mean, we're already struggling with our healthcare as it is. I mean, you know, this is all preventable medicine. It really, really is, in my opinion. In my opinion.
All right, Care Bear, are you comfortable if I hop on to the next point that I have here?
Absolutely.
All right. So as of October 2018, most people are aware that medicinal cannabis consumption became legalized in Canada. I'm going to talk about a little bit about existing pain management medications. So some of the current existing pain management medications for pain, such as cannabis's medicinal properties, aren't strong enough to manage existing pain from pre-existing medical conditions. So as Karen so generously shared with us, she like living with fibromyalgia is what like introduced her to like the street market for substances. A lot of people are on different forms of medication to manage pain, like from pre-existing conditions. With the incorporation of Safe Supply, this provides a safe, stable environment that people can have access to those pain medications and have like even a plan of care, working with a doctor, working with an individual to individualize these plans.
A lot of folks will say, well, we already kind of have that in play. We have the methadone program. Yes, we do have the methadone program. And I don't, a lot of folks, studies that have taken place and the folks that are on Safe Supply, this isn't their first kick at the cat. They've usually gone on the methadone program. They've tried Suboxone. They've gone cold turkey. They've been into treatment. They've gone into a lot of things and it's not worked for them. Just an example of the methadone program. I'm on methadone. It does work for my pain. But with that being said, I also have a place to live. I also, you know, I'm working full time, so on and so forth. But just to give you an example, back in the day, on one of my jumps on the methadone program, my children were young, and I was trying to make it work. And I had a part-time job, and I worked at a 7-Eleven on the weekends. The methadone place is only open from 9 until 12. My shift, Saturday and Sunday, was 7 to 3. So that just ensured that I am not getting methadone those days. So every time I worked a long weekend and I would have 7 to 3 shifts, I could not go down and get my drink. By the third day, you are then cut off the methadone. You can't go 3 days without it. So you have to restart. So what that happens is at a restart, you're cut down to your half dose. You get half of it. So let's say you were on, for simplistic reasons, you were on 100 milligrams or milliliters. So by the Tuesday, when you went back and you worked your Saturday, your Sunday, your Monday, you've now gone 3 days without methadone. So you're not feeling that great. You're now down to half of that dose. So, you know, every time there was a long weekend, I was back to zero. I was like 3 steps forward, 3 steps back. With the methadone program, you need a health card. A lot of our folks don't have health cards. Any of the stuff that they do have gets stolen. They don't have a safe place to live. They leave their stuff here. They get their stuff taken, so on and so forth. If for whatever reason somebody got picked up on a Friday night for missing a court hearing because they're living with no fixed address and not getting their mail, so they're picked up on a Friday night and it's the long weekend, they're 3 days without methadone, they're kicked off again. You go into jail for whatever reason, it takes a good week before they even get your prescription and get you organized. So you're kicked off again. It's not a user-friendly program. It is if you've got certain things in place, but a lot of folks don't have those things in place. For some folks, it just does not work. It just does not. Some methadone programs that run in the city will only take you so high. So, and their thought process behind that is you should only use X amount for addiction, and they won't take you as high as people need to go. With the strength of fentanyl out there, I mean, we're seeing that it's the tolerance is more and more and more. We need to get onto this. We really do.
I also just think the assumption that everybody wants to be on methadone or Suboxone is another valid point. It really doesn't meet people where they're at, right? And like a lot of doing outreach work and working in the community is really the emphasis of meeting people where they're at, right? Letting them be the voice of their own journey, when the reality is like we're out there and we're like really pushing for methadone or treatment or Suboxone, that's really not honoring a person's journey. Whereas like with the intervention of safe supply programs, this can honor a person's journey and walk step by step with them. Maybe they don't think methadone right immediately because they're not at that place, but who's to say it can't happen further down the line, right? So I think ultimately it's just about setting our folks up for success.
Absolutely. It's giving in my opinion, it's giving folks control over their addiction. Okay. You are now taking this addiction that has been ruled by street drugs, the black market. Because let's be honest, I mean, our drug dealers are not paying taxes. You and I are. It's giving the control back to the person. They are taking their medication. They are coming in daily to pick up their medication. These programs work a lot. They're a lot more user-friendly per se than the methadone program. The methadone is at a certain location. You go pick it up, you've got these hours to do so. Safe Supply could be at the overdose prevention site, which is open 7 days a week from 9 to 5. Yes, there's still stipulations in there and you need to be there at certain times. But I mean, it's giving control back to folks. They get their Safe Supply. They then go on to the overdose prevention site and they can use and they can know that they're being looked after and taken care of. One of the biggest things when I did start the methadone program, because I am stable and I've got a home and I've got all those things and a health card and so on and so forth, and that's the only choice that I had that was out there was the methadone or drug seeking, and I just couldn't do it anymore. It kicks the poop out of you. It really does. It's what you do all day. Once I got stable on the methadone, the first thing I thought that comes to mind, and I talk to this with other people all the time, is like, my gosh, what did we do all day? Drug seeking. That's what we did all day. I couldn't make the kids lunches. My day was consumed with looking for medication.
Not to mention the amount of risk that can come from situations that you're putting yourself in if you're
Absolutely.
going to find illicit street substances.
Yeah. I mean, a lot of drug dealers don't just sell one thing. They've got, they're out to make money, and they've got, they've got other things for sale. So, I mean, you're not just dealing with folks that are seeking fentanyl or opioids. You're also dealing with folks that are, looking for crack and all different kinds of substances. And, you're dealing with, they're all illegal. So the police could be watching. You could be putting your life at risk and losing your freedom because you're trying to keep from being sick. And I'll tell you, the sickness, I would never wish this on the worst person I'd ever met. It is just horrible. I'd birth babies before go through that pain again. I'll never forget that pain. I mean, you get the sickness, the pain in my legs was horrific. If there was pain of vision, oh my God, I can't even describe it to you because there's no pain that's like it. It was horrific.
You kind of brought me to my next point unintentionally, Karen. I think that's lovely. It really reduces criminalizing these marginalized folks. You know, as Karen had mentioned, when you're out and you're on the streets and you're looking for, you know, your substances, there's a high factor of criminalization, whether it be because, you know, you're trying to secure your substances, you're trying to secure money for your substances, you're entering like unsafe facilities, the like behavioral aspects that come with like trying to make sure and secure your substances. There's a high criminality rate, for already disenfranchised individuals, right? Because they're constantly being told where to go, where they need to be, what they're eating, when they need to be at this appointment. This is really a way, as service providers, we can provide power to the already disempowered individuals in our community.
And let's talk about women. I mean, you know, in all fairness, one of the biggest eye openers, because I came from a place of having my pain medicine being dispensed through a doctor at first, I was not privy to street life. It was a big eye opener for me. I soon discovered, you know, the women that were selling their bodies just so they could not be sick. It broke my heart. It really did. And you know, just because you're visiting with folks that are selling, you know, they're selling pills, they were selling crack, they were selling all different kinds of things. You're seeing all different walks of life. But I mean, you know, some watching some women just give themselves up because they needed a toke of crack. It's a male dominated business, without getting into the stigmas of all of that. But I mean, it was heart wrenching to see that women were being used and abused in that sense, just for the simple fact so that they could get high and make the sickness go away. It's heart wrenching. It really is.
Well, it's like exploitation, right? Like
Absolutely.
yeah.
Yeah. Yeah. Yeah. And then, of course, you know, just with our facts and stats that we talked about, you know, sexually transmitted disease, you're not going to the doctor for that. You're not getting that checked, especially if you're spending all day looking for your medication. That's the least of your worries. And in all fairness, you don't really want to bloody know if you've got something, because that's another thing that's on your list of, you know, life issues per se.
Or medication that you can't afford.
That's right.
Yeah.
You know, yeah. Or the fact that you're going to have to go and see another doctor who is not going to understand your addicted lifestyle and who is going to pass judgment on you again. And it's like, you know what? I'm done with that. I don't, you know, I don't want to deal with that. And fair enough, you know. Who wants to go see somebody that's going to look down at them and treat them like they're dog dirt on the bottom of their shoes? Don't want to. I remember once I went to the hospital, and I had gone because I had osteomyelitis, which was the pain, the bloodborne infection, pain in my back. Anyway, this was my third visit. I had this excruciating pain that kept knocking me to the ground. So once they get in there, they've wrote on the top of my form, Oxycontin addict, methadone recipient. I got this young doctor come in, and I thought, oh, great, we've got a young doctor that's going to understand methadone. Anyway, she came in and she looked at the pamphlet and looked at the form, and of course read Oxycontin addict, methadone recipient. Oh, you're on methadone, she said. I said, yeah. And the thoughts in my mind is, oh, great, she understands, and this is going to be a great, you know, positive conversation, and da 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 da. So she said, oh, I'll be right back. So she disappears and comes back in, and she has a full face mask on, which is nothing today in the world of COVID, but back then was quite shocking, and big black gloves up to her shoulders. And I said, I'm on methadone. I don't have leprosy. So she kind of looked at me and she said, forgive me. They teach us about methadone 5 minutes. You're a heroin addict, you're probably HIV, and you're probably Hep C. So I need to protect myself. I then wanted to inform her of my story, of my life. I don't do heroin. I've never done heroin. And anyway, after a little while, she went and called the methadone clinic. And what I had told her, they told her the exact same story. She came back in, took her gloves off, took her face mask off, and apologized profusely to me and said, "I'm sorry.
But
I
the fact
didn't know."
that she didn't believe you? She
No,
had to call and follow up.
right.
Okay,
Yep,
sorry.
absolutely. But I mean, and you're gobsmacked at that, and I'm looking at it in this realm saying, she listened to my story and believed me after the fact. You know what I mean? That's where, unfortunately, that's when we're living in this realm, these little moments of gain are amazing. And whereas you're looking at it from the prospect of like, oh my gosh, how could somebody even not believe you? It's very commonplace. People shouldn't have to live like that. We're living in the year 2020, you know?
It just shocked me that like the follow-up call was placed to your actual methadone doctor to confirm all that stuff. Like, when did we stop believing people on their own bodies, like in relation to their own health? Like,
Unfortunately, I I had that big red label at the top. I'm an Oxycontin addict and I'm on methadone. So I'm obviously there. I'm there for a pain problem, so I'm drug seeking. This is in her mind.
mhm.
Unfortunately, the methadone clinic was able to, confirm everything that I had told her. We were able to make excellent progress, and she vowed that this would never happen to that she would never make that mistake again. And I thought, what a win. What a win that was, you know? But I mean, it shouldn't be a win. It
Yeah.
shouldn't be.
It shouldn't have to be a win.
No, no, it shouldn't. Right.
I'm gonna move on to our next point,
Oh,
Karen.
sorry.
So my next point that I had written down here from Safe Supply from the perspective of a service provider, reducing isolation for marginalized populations. So with the increased anxieties that are the result of the global impacts of COVID-19 and the incorporation of access to safe supply can really reduce barriers of isolation that come with substance use disorder. Again, it's that connection with accessing their safe supply. They're coming out, right? They're connecting with that doctor, they're developing rapport, which can only provide referrals to additional services for whatever needs an individual might have, right? It's that first step, it's that first piece, it's the first point of contact. um, and I believe it can be a very pivotal time for individuals. I didn't
It
know.
is. It's almost like the sun rising. It really is. It's almost like, you know, it, it's such a hard world that folks live in every day, trying to just survive.
And these are members of our community, right? Like
Absolutely.
these aren't people who are like in different areas or in rural locations. Like, these are actively members of our community, right? And they're facing like barriers upon barriers of isolation. Um,
It makes you wonder. One of the conversations that I have with my mom, and it's this is a very valid point. Even though my mom went through all of this with me, she'll tell you she just doesn't understand the addiction. She's always been one of those people that can just get on with it. If that's not what you want to do, you go forward, you get away from it. It doesn't work like that for me. She doesn't understand that, and that's fine. But I've said to her time and time again, at the end of the day, Mom, if we were to open up Safe Supply, what difference would it make to you in your world? It really wouldn't make a difference if somebody was given the medication, but it would make a difference that they wouldn't have to steal stuff to get money for their medication. If there was Safe Supply, that cuts off the drug dealer. As we've seen with the study in Scotland, they didn't want the street drugs anymore because it was cut so badly. people would move forward. They really would. And really, what difference does it make to anybody else if somebody, well, it does make a difference because they're not, it's not a drain on the healthcare. What it's going to save down the road or what it's going to save in overdoses, that should be worth its weight in gold. Even if people can't see the human side of things, even if they look at it from a monetary perspective, the money that this would save in healthcare costs, I'd be interested to know how much an overdose costs. We've got the paramedics coming. We've got the fire department coming. We've got the police coming. That's if they call 911. A lot of our folks won't even call 911 because of the stigma and whatever else that goes along with an overdose. And we don't want people to know that we've overdosed. But let's say 911 is called. We've got all of those three service providers coming out. Then that person is going to the hospital and they're taking up an emergency bed and being monitored overnight. Like, just how much is that costing when it could be totally avoided? If we were to give safe supply, people wouldn't need the fentanyl on the streets. They wouldn't need it.
You're like, this is perfect because you're helping me get to my next point, which is great. I love this. So supply and demand for illicit street substances. Again, I'm going back to like the phases of COVID and what it has done to the world and specifically what it means to the landscape of like illicit street substances. So like because COVID and like restrictions have been implemented, access to safe supply would reduce the risk of people overdosing due to contaminated substances or even cross-contamination of substances and inconsistent supply, right? So like, just because COVID happened doesn't mean substance use stopped happening, right? And there is like still people in our community, in our world that are actively engaging in substance use on a daily basis with the overwhelming risk of the implications of closed borders or closed like shipping, right? And what that has really done is really impacted on a street level for those illicit substances that are on street level, right? There's still a need for these substances, but no access to these substances. So what's happening is they're finding other ways to create these substances with increased health risks and increased detriment to the body. So again, if we implemented like a safe supply program, we would really reduce those risks and reduce the need for people to like drug seek on a street level.
Absolutely. I agree. I don't know if you remember this, Corey, and I just want to give people that are listening a little synopsis here. Remember that time we had worked on the van together one night, and we had just started the COVID, the outbreak had just started. We were just implementing masks and social distancing and so on and so forth. And I don't know if you remember this, Corey, but you were in the van and you were handing out stuff for folks, little snacks and what have you. And I remember you yelling from the van and asking people to please give themselves, the distancing and put your masks on and da. And you and I spoke afterwards, and I said to you, did you notice how many times you had to say that? And you said, yeah.
Like 6 or 7 times.
Yeah. And I said, do you realize that, unfortunately, it's the least of their worries. They can't worry about that because they're so entrenched with just survival of getting something to eat and moving forward, that what is in, that we're all worried about COVID. And unfortunately, they're just taking care of each other. They were making sure the other, that person was okay. Are you in the line? Okay. You know what I mean? And that wasn't a concern with them, only because they're fighting for survival, just to stay alive and on top of their world. Yeah.
Well, like, and just to add to that point, van has continued to run throughout COVID with, again, implemented measures for safety. But again, just to echo what Karen is saying, the amount of times that I've seen individuals coming out to access supports from the van. They're not even coming out to access supports from themselves most times. They're coming out because their friend or who they refer to as their street family doesn't have the means or doesn't have the capacity, but they do. So they'll come out and access the van and grab one of our outreach nurses and grab an outreach staff and be like, "Can you come with me and come to this person?" So I bring this up because I want to like rehumanize like our folks. These aren't just entities that don't have faces and don't have names. These are people that care and have compassion. And, you know, despite the layers and layers of stigma or the layers and layers of barriers that they face, they still find a way to like show compassion and show empathy and show strength within their own realm, like advocating for each other, advocating on behalf of each other. And I think that's really, really important that we also mention that, because I think that's, again, when we talk about substance use disorder and as a community, I find that it really has a way of dehumanizing these people. But that's just it. At the end of the day, these are still people. These are people of our community. Sorry, Karen, I went off on a tangent there.
That's okay. It brings up something that my dad had said a long time ago, and I never really ever understood this. And you know, a very deep thinking man and so on and so forth. And he said, you know, we're a first world nation allowing some of our people to live in third world conditions. Never understood that until I've embraced this job and seen how, you know, there is actually a hierarchy, you know. And one of the things that I have a hard time getting my head around is the fact that, you know, yeah, there's different levels of income and so on and so forth, but at the end of the day, we're all still people, you know. And yeah, there's different levels of monetary stuff, but you know, we all deserve a right to be taken care of, loved, and respected. It doesn't matter what you're into per se, and especially if it's you know, if it's addiction, and it's, yes, it hurts other people in and around the family, but for the most part they're only hurting themselves, you know. Yeah, the family does get hurt and so on and so forth, but you know, essentially they're doing it to themselves. How do we not treat them like people?
I think that's a great point to stop for our like discussion and move on to our next segment. So right now we're going to talk about some stats and some informative reads where we pulled this information from. Karen has been so wonderful in terms of like compiling resources for us to work from and gather information from, as well as like broaden our knowledge around safe supply programs from. So I'm going to hand it over to Karen to introduce you to some of the readings and the information that we pulled.
So a lot of our reading and our information that I got was actually from the government of Canada. If you go in and do the Google, you know, it government Canada has done a lot of study on this, more so in the last little while with COVID, because of the impacts of COVID. But there was some great information on there, and the government of Canada, and just do safe supply. There's been studies around this is not new. It's really not new. You know, Portugal, we talk of a lot of, and I want to put out there that safe supply is only one part of a program. I mean, we can't just sit here and say, okay, here's your medication, move on. There has to be other parts to it as well. And you know, on the weekend, there's people talking about detox. Detox is a great idea, and so on and so forth, but it'll take time for a detox to get up and running. We're talking about something that can be implemented right now and to stop the dying. Another resource that I was able to get some information from was the Ontario HIV Treatment Network. They had a great reading article. They really did. And you were able to pull up all kinds of information on studies, studies of a doctor at Queen West. He has been dispensing Safe Supply, and they've been able to do it and done a study with that. His thoughts were he had the tools to help folks as opposed to sitting here watching them die. And I thought, what a great synopsis is, this is all totally can be changed and preventable, So that's the two little things that I had brought up, that I got a lot of this information from. Yeah.
And now we're going to move into our portion for any question and answer. As an aside, before we jump in, I just want to say thank you for being with us today and being privy to our discussion. Karen, thank you for all of your help compiling all this beautiful knowledge and sharing your experience in doing so.
Thank you. And thank you, Corey. This was really great. And if it sounds a little choppy here and there, it's because we're doing it kind of live and from the bottom of our hearts. We do have a little script. But I mean, for the most part, we wanted to keep this as real as possible and as casual as possible, as two people having a conversation and trying to bring our everyday world to your world. So that's it. So thanks for joining us. It was quite fun, and we've got some questions here. Yes, big loves, big loves, big loves. Yes. Okay. So our first question was, why should I care about Safe Supply if I don't know anybody living with addiction? What's your take on that one, Cor?
I think, again, I just want to echo the fact that maybe we don't actively know anybody sometimes living with substance use disorder, but that doesn't mean substance use disorder isn't happening in our community. And I think it's about the importance of having a greater awareness and a greater compassion to everybody in our community.
Absolutely, I agree. Why should I care about Safe Supply? Because I think addiction has touched more people than we know. What's going on right now in the world kind of reminds me of back in the day with Prohibition. It seems very much the same. Once they opened up the alcohol and made sure that there was no bathtub gin being made and poisonings and so on and so forth. I'm not saying addiction is not a real problem. It really is. But with that being said, we have alcohol. We're able to go buy it. Not everybody goes and buys it all the time. And I think it would be the same with Safe Supply. I mean, I think people would, it enables them to move forward. And I think a lot of people have been touched by addiction. I think we know more people than if we were to sit and think about it, which is probably something we don't do every day. I think we can think that, yeah, I know somebody that's it's touched our lives. Yeah.
I also just wanted to share with the implementation of Safe Supply programs, it enables people to see a light throughout the darkness, right? Like it gives people a chance at hope.
Absolutely.
Hope that their life could be a different way tomorrow, right?
Yeah. Absolutely.
Okay. I'm going to fire the next question at you, Kara.
Yep.
How is Safe Supply different from methadone and Suboxone?
So Safe Supply is different from methadone and Suboxone, as methadone, as I said, is not really a user-friendly program. I mean, you have to have some sort of stability in your life. And methadone doesn't work for everybody. Suboxone doesn't work for everybody. It's like you and your partner, Corey. He's got diabetes. You just get insulin. That's not how it works. as at all things like it's the same as with methadone and Suboxone. Each person is different and different people. Um, the difference on Safe Supply as and Suboxone and methadone is Safe Supply is they're getting their medication daily, which is similar to methadone and Suboxone, but it's meeting the person where they're at, as what you said. It's not telling them that they need to get off what they're taking. It's giving the choice back to the person. I think that's where I'm going with that.
Why don't people with addiction just go to treatment? So this is one I think we both hear very frequently. I think the reality, a big portion of this question is treatment's not that easily accessible. The reality of treatment programs is some are specified, some are at a great cost, some have low accessible beds available, but the wait list to get into some of those accessible beds can be 3 to 6 months from time to time. And if somebody's coming and they're like, I want to work on using less substances, well, when they're referred to a treatment program, that means abstaining from all substances, sometimes up into including cigarette smoking, which when you're trying to navigate away from one addiction, it's hard to let go of multiple addictions. That's like telling me I can't have a coffee in the morning. Like, I would be a bit of a bear. Is there anything else you wanted to add to that one, Karen?
Absolutely. Why? What if they don't want to go to treatment? What if they don't? You know, what if they don't see a reason in their world that they need to stop?
Well, what if treatment means sacrificing their housing?
Exactly. I mean, that happens too, you know. Going to treatment, it's not easy for the average person to navigate that system. I see it every day. Social workers trying to navigate the system and get a person into treatment. I mean, there's hoops and whistles that you've got to go through to get to it. I mean, it's and not everybody wants to go. I see a lot that families will say, well, you can't come back home until you go to treatment. And then if somebody goes to treatment, they call the mom up and say, listen, mom, I'm done with treatment today. Can I come back home? Well, no, honey, you've got to you've been there for 28 days. That's great, but I need to see you living like that for a while before I'm going to let you come back home. So that person is then left in limbo again, has nowhere to go after being in treatment for 30 days. Being in treatment and getting themselves organized within that realm is great while they're there. It's when they have to come back home and they have to go back into the shelter system, or they have no place to go to. Family's not going to take them back. There needs to be, I think it needs to be all encompassing. Treatment needs to be for families as well. So families can understand the addiction as well as the person that's being treated. That's if the person wants to go to treatment.
Also, you just brought up a very great point. Some treatments only address the addiction. They don't address what's underlying the addiction. Or the substance use, right? There could be trauma, there could be mental health, there could be a plethora of different things underneath the substance use that have led to the substance use. It could be like pain management.
Absolutely. I mean, I know my sobriety did not come until my mental health was in check. And that's another thing, we need to embrace the fact that sometimes that's part and parcel of it. And, I think we need to do a better job of marrying those two together. and try and work together as a team. If somebody is looking at going to treatment, there doesn't seem to be a lot of that. There's focus on stopping the addiction, but not a lot of help with what got us to that place. You know, in all fairness, those things that were so unbearable at the beginning of the addiction, they're usually still there. And if that's not dealt with, they're just going to rear their ugly head again. You know?
Also, just like you had mentioned earlier in our discussion, those things that led to the substance use or the addiction in the first place will still be there underneath the surface, as well as compounding factors of some decisions that you may have made throughout your addiction layered on top of that as well, right? Like,
Absolutely. I mean, even me being sober today, I mean, there's parts of my addiction that dance in the back of my head that come, you know, that rear their ugly heads quite often. And it's like, you know, I need to work past that. I mean, and my, you know, I'm talking about my kids in general here. They probably don't even remember half the stuff that I'm remembering, but I remember it and I play it over in my mind. So, I mean, there needs to be a whole encompassing, you know,
approach.
part of the treatment package. It needs to be a whole package, but right now, my main focus is to stop people from ingesting these potent substances. I mean, recovery can be whatever you want it to be. It doesn't mean just abstinence. It really doesn't.
All right, I'm gonna cut us off there again. I'm just gonna reread something that Karen has lovingly wrote for us. So what Karen and I would like to do today is in a casual and comfortable way, give our thoughts and feelings on Safe Supply using our skills and our experiences. By no shape or form are we medical people with degrees that say as much, but what we are is caring, loving frontline workers with a history of opioid dependency and working with individuals who try and survive the crisis in the best way we know how. And it's killing them. And we would like to speak about that and try to let you into the world where Safe Supply could make a difference. So again, I just wanted to reread our disclaimer there for you. And that will wrap up our session today. Thank you again for joining us for Coffee with Karen and Corey. Arch out.
Thank you. That was wonderful. Are you guys able to stick around for a few minutes, even maybe just 10 minutes, to answer any questions if people have them, or if you have anything else you want to share post-recorded session, if you have any other reflections or pieces that you want to add?
Yeah, we're not very smooth at that. I can tell you that much. My gosh.
Outreach workers, not movie stars.
That was great. It was really good. Yeah.
We are not Diane Sawyer. Any questions, anybody?
Feel free to type them into the chat, or you can unmute yourself if you want to share and keep your video on or off. It's totally up to you. I have a question. Do you know if doctors get any more medical training now? Like your story, Karen, is like horrific, and also like, yeah, not unique, which is upsetting. But I have to wonder if like the training has improved any, especially like considering the like current epidemic that's going through, and like.
I'm not 100% on that, Jasper, but I think it's something that I should look into and find out. So if you don't mind, I'm going to do that, and I can send it back to you, and you can share with everybody who's ever interested in finding that out. I would hope and pray that they have taken some more information, you know, like just as I said, that, you know, methadone's for heroin addicts. Like, you know, even in that day and age, the point of OxyContin did not even come up in the conversation with this doctor. You know, it was heroin only. And when I had the thing in my back, I went and seen an infection specialist, and the first thing he said, well, heroin addicts get this. So it just irritated that, you know, that's where their mindset is. But I will look into that and get back to you, and you can share with whoever wants to know if you're okay with that.
Yeah, that's great.
I believe it was mentioned in the text. Like, I think it's I think in order to explore it more in depth, if you're going through medical school, I think it has to be a specialized field of interest as opposed to like in part with like general education.
So more of like an addictions route as opposed to
Yeah.
like the overview. Yeah, that's right.
But you'd think that they would give you a little bit more with it being such a part of our world, with this epidemic, and I mean, I would hope so, but let's look into that and find out for sure.
Yeah, totally. I feel like it really fits into like social determinants of health, but also just like pain management in general, which is like a huge portion of healthcare right now, especially. So,
Absolutely. And we don't have any pain specialists in Guelph. We just don't have anybody that is taking anybody. Our last pain specialist actually ended up killing himself because I would understand the pressures being so much of, in one sense, giving people the relief from the pain, but in the other sense, you've got Big Brother saying don't dispense opioids. We do know opioids do work for pain. They do. The problem is you need more and more as time goes on. You know what I mean? And you would think, I have read a lot of research on the fact that methadone, with methadone, you don't go higher and higher for however it works. It's a synthetic opioid. You can stay at a dose. You don't seem to have to go up like you would on Oxycontin. I don't understand why a lot of docs don't dispense methadone as a base pain relief, because it does work for pain, and then give something else for breakthrough, because methadone takes away the addicted behavior and keeps a constant in the body. So you've got a constant pain dispensing unit within the body, and then if you happen to be in more pain that day, you can take another opioid to help get rid of that pain, but you don't become dependent on it because the methadone works. So I don't understand why they don't marry those two together and get somebody. I have read it, some doctors doing it, but it's not a common practice, which I find bizarre because they use the methadone as for addiction. So I know.
Just to like keep it a stigmatized medication as opposed to like using it to its full efficacy.
Absolutely. So
your presentation was very moving and also deeply infuriating. Yeah. It's not a lot of stuff that I didn't already know, but thank you for sharing. And it's so frustrating. And yeah, I hear your pain.
Thanks. We'll start a fan club.
Yeah.
Hi, it's Andrew here. I finally unmuted. I just wanted to say that, there's so much to unpack from what you guys shared, and it was such an incredible presentation. Like, I loved the parallels between the diabetes and the fibro diagnosis. One thing I wanted to share is just, you were talking about the fallout with the families, and that it's, it's primarily the substance user that deals with the fallout. Most of the fallout that the families deal with, it doesn't have to do with the substance use. It's the criminalization of it, and it's the stigma surrounding it. That's what affects the families.
Absolutely.
It's not so much the substance use.
Absolutely. One of the things that I do say a lot: don't hate the addict, hate the addiction. You know what I mean? Because sometimes, when you are addicted, you get backed into corners to try and get your medication. You do things that you would never normally ever do. As I said at the end, there's some things I still dance with that I have a hard time with that I did. And it was just pure the addiction. But the family there's nothing for families whatsoever. Even if somebody goes into treatment and comes out on the other end, there is no knowledge for the family. The family knows what they have lived through with their person that they love, and they're coming out of the other end on it, and yeah, it's a tough kid. There needs to be, I think, a whole encompassing thing for the family, for the substance user, and everything.
Well, like similar to alcoholism, they have Al-Anon for families.
Right.
I think when we're looking at treatment programs or like substance use disorder, I think there needs to be equally as many available resources for the family.
Yeah, here in Kitchener, I work with, I'm the peer for specialized mental health, which is the long-term mental health unit at Freeport Hospital. We also have a family navigator that I work with, but she works 20 hours a week, and it's for all of KW basically. And
Holy.
and her job is, I love the fact that she doesn't know about the patients at all. It's all about what does the family need, and helping the family become more educated, helping the family learn how to set boundaries and take good care of themselves.
Absolutely. And that's part and parcel of it because, you know, as you said, that, you know, they see the negative aspects of the, you know, what goes on within the addiction, you know, they need those supports too. I mean, her job is very important.
Yeah, and one of the things I'm often saying when I'm advocating for a role is just the fact that when I was struggling and unwell, um, one of the reasons I didn't turn to family was because I was afraid of being a burden on them.
Mm.
And if I knew that there were supports available for them, if I knew that they were able to get help if they needed it in being a support to me, then it would have been easier for me to reach out.
Absolutely. Yes, that's an excellent point. Absolutely. Yeah. I mean, even when we're living within our own bowels of hell, for better, lack of better words, I mean, we don't want our families to have to go through what we think we're putting them through, and there is no help. There is no help for them. You know.
Hmm.
But yeah, I hear you, Andrew. Like if we were able to create a more comprehensive support system for families, for our like care support systems to also feel supported, then this comes back to a big theme of this conference, which is like, how do we cultivate community care in a time where we are so isolated? And like, how do we start to like reach out and really support one another in meaningful ways so that you can reach out and not feel like you're overburdening and overwhelming somebody or putting somebody outside of their window of tolerance where they can support you. Or if they are pushed there are other supports. We can all kind of lean on each other in an interdependent model, as opposed to just like trying to keep each other standing out of desperation. You know?
Yeah.
Or even like education around like where addiction comes from, what
Yeah.
leads a person into addiction. I think is because I think I'm just thinking my specific family, and as much as I love my family, when you talk family, there comes a lot of judgment, right? Because who not judge us the most, except for the ones that are raised alongside us or who have raised us, right?
Yeah, and have their expectations of you.
Right. And
Yeah.
I think just some means of like even just educating people on like the realities of addiction, because it's I say more often than not, people don't just wake up and they're like, oh, I want to grow up and be an addict. It's like a journey that's essentially like goes through like severe trauma or like underlying mental health or like undiagnosed mental health, and like bringing the broader understanding and the level of education that we see now working in this field, and like really making it accessible and available for families and folks living with addiction, right?
Absolutely. And like we see that like especially like when we talk about like families of addictions, or like where like addiction runs in a family, like we often see legacies of like intergenerational trauma, like multiple barriers to healthcare, multiple barriers to wellness, which like result in like mental health afflictions because you're struggling all the time, or your brain is like less adapted to whatever your context is, and it causes you to struggle, right? And it gets tiring struggling all the time, and so drugs, you know, are one of those only opportunities for release or for like relief from that. And so like giving families even the like language or the like education to actually start to address this and talk about this, right? Because it's easy to shame your family member who might be like using different like street drugs, but you might have like an addiction to prescription drugs that, you know, is fine because it's prescription, or it's fine because it doesn't come with the same stigma yet or now.
Yeah.
You know, absolutely.
Well, and it's just, I think you brought up a very interesting point, and like even the hierarchy that exists within the substance use world, right? And what that looks like, you know, and I think that's something that needs to have a part to play when we're talking about safe supply too, is like really demolishing that hierarchy that exists.
Yeah, because it's not so much a question of like quality, like merit or integrity, right? It's entirely a matter of circumstance. Like what happened to you in your life, and where's your context, and what care can you get? And we see this a lot when we're talking about like the right to a safe supply, or like, you know, some of the conversations around like abolishing police. It's like we know what community care looks like because affluent communities already have it. You know, like affluent communities who have like kids who are addicted to cocaine, like they're not going to jail, they're not being put in these same situations that would cause this cascade down. And I feel like that's like a really topical conversation now within COVID, of so many people having like housing insecurity and having, you know, suddenly not being able to navigate a lot of these realities that are being thrust upon them. It's like most of us are much closer to being housing insecure and homeless and addicted than we are to, you know, becoming like very affluent or like very well off. Like this is not a distant reality for many of us. So I think sharing those stories really kind of brings that home.
Andrew, thank you so much for like the awesome question and the awesome comments.
Yes, thank you. And for what you do.
And thank you for everything you shared with us today. It's phenomenal. I just wanted to mention that with Portugal, when they decriminalized everything, one of the big drives for that was that they were discovering that every time they criminalized something and tried to remove it from the streets, something more dangerous and more lethal and harder to enforce came on the market. And that's what we're seeing here with the fentanyl, is the same thing.
Absolutely. Yep.
And then 10 years later, they looked at a retrospective of what's changed. And their heroin was their big substance that was an issue in 2001 when they decriminalized. And their addiction rates were half what they were 10 years later. And drug-related deaths across the board were down by 90%.
Yeah. Like that's phenomenal. 90%. What gives you those kind of stats? You know,
Yeah.
that's crazy. Yeah.
And part of it was that just decriminalizing it meant that you didn't have to hide, and you could seek help when you needed to.
Right.
They also took all the money they were spending on enforcement and they put half of it into treatment, so you could get what type of treatment you wanted, when you wanted it, where you wanted it. You could have people come into your home and like really problem solve, like
yeah,
really on the like where you need the help.
Yeah.
The other half of the money went into job creation, so actually subsidizing jobs for people with a substance history. Because, you know, as sorry, I forget your name, I'm horrible with names, but you talked about getting the peer job and like, oh my God, I'm getting paid for work, and there's meaning and purpose, and suddenly, you know, you have a drive to find a way around the substance use a bit and figure that out and improve your life just in general.
Absolutely. Yep. And I say all the time that this job has given me my sobriety. It's given me a reason to move forward. I'm now 50 years old, and it's taken me 50 years to come to terms with the fact that I found something I'm good at, and it's something that, you know, society says, oh, you shouldn't be doing, but you know what I mean? It keeps me sober. It really does, to give back to you know, my people. Absolutely.
You must try.
Yeah, and just in general, I find our culture has it totally backward. They think, oh, clean yourself up and then you can go out and get a job.
Yeah.
Instead of, you know, help you find meaning, help you find purpose, help you rebuild all the things that reinforce the dependence on substance.
Absolutely. Are you running for president anytime soon, or prime minister? Because you got my vote there. Just saying.
If I could have all the power and none of the accountability, that would be great.
Yes.
I used to think I could solve all the world's problems. Now I just feel that it would be a totally different set of problems.
True. You guys are amazing. Thank you so much for hanging out with us.
And thank you.
Thank you.
Thanks.
Thank you, Jasper, for like hosting and facilitating all of it.
Oh my gosh, of course. Thank you so much for all of these fruitful conversations and for all of your contributions. That was beautiful. We appreciate it. Are you folks sticking around for a minute? We'll be moving into the next session. We're doing a speed social. So if you'd like to stay, it will be especially speedy. It will be like 24 minutes long. So
I'm running the new exchange program today, so I gotta run.
yeah,
But
that's
thank
it.
you guys have been a great audience.
Yeah, thank
Yeah.
you so much.
Thanks so much, guys. Really
Someday in the
appreciate it.
future, I might have to get you guys out at Freeport to do a presentation for our staff there.
Oh, absolutely. We're in. Jasper's got our information and we're on the website, on the ERT website. Yeah, we'd be more than happy to do
Perfect.
that. We'd love it. Yeah.